Barium study is the best modality for the detection of the esophageal strictures, whether of benign nature or malignant nature. As far as the benign esophageal strictures are concerned, it is divided into three categories. The inflammatory is the topmost. In the inflammatory, the reasons of the development of the esophageal strictures are the peptic ulcerations. In the peptic ulceration, actually it develops in later life, and it's seems to be associated with the hiatus hernia, and the area which is usually involved is the esophageogastric junction. You will see ulceration over there, and there will be a particular presentation on the barium studies which I will show you in the next slide. This is the barium study, and here you can see that the contrast is clearly outlining the esophagus, and on the top you can see that the proximal esophagus or cervical esophagus or upper mediastinal esophagus is clearly outlined without any evidence of stricture. But soon after that you will be able to see that in the mid and the lower esophagus is showing stricture formation, but the smooth wall stricture. At the distal end there is a radiolucent patch. You can see that this is because of the ulceration, and this is peptic ulcer. Peptic ulcer is an inflammatory type which is resulting in smooth wall esophageal stricture. Next comes scleroderma. Scleroderma is the next inflammatory condition which causes the esophageal strictures. Scleroderma is actually multiple organs connective tissue disorder, and which resulting into reflux because of the wide open cardia, and it leads to a stricture formation. There will also be poor peristalsis, and in scleroderma, which is multiple organ disease, the esophagus is the commonest organ involved. Here on this barium study you can appreciate there is a wide open esophagus. That's because of the deficiency of the connective tissue due to the scleroderma conditions, and at the lower end the white arrow is pointing towards a stricture formation. That was because of a continuous reflux, and it ended up as a stricture. But look for the wall and the surrounding area. This is a smooth wall stricture, and usually in scleroderma patient you will be able to see such type of a stricture. But do not confuse it with an achalasia, because in achalasia there will be a particular presentation of a rat tail appearance. This is how the scleroderma appears on the barium studies. With regards to esophageal stricture of benign type, in the inflammatory category, the next come is corrosive. In corrosive, alkali plays a vital role, and in acute condition it causes edema, spasm, ulceration, and even loss of mucosal pattern. Especially you can observe this on the barium studies, that the hold up of contrast could be seen at the aortic arch and the gastroesophageal junctions. These strictures happens to be quite long and symmetrical, and in the next image I'm going to show you on the images how it will appear and how it will looks on the barium studies. This is the barium study, and on this study you can appreciate that the lower esophagus has got stricture, but this stricture is benign in nature and it shows smooth walls, although you can appreciate the pre-stenotic dilatation. This is a clear example of the corrosive stricture, and this is benign in nature. You can appreciate that there is no wall irregularity, there is no granularity seen. However, pre-stenotic dilatation can be seen because of the stricture. So this stricture is called as benign stricture. Benign smooth wall esophageal stricture can be caused by inflammatory process, and the next category is iatrogenic, like if the patient is on prolonged NG tube and this NG tube act as a foreign body. So due to the response of the foreign body placed for a long time within the esophageal lumen, this stricture ensues, and this stricture will be similar to the strictures of the other inflammatory origins. Have a look to this barium study. You will be able to appreciate a long smooth wall stricture, mostly involving mid and lower esophagus. That is because of the prolonged NGU tube, and this is because of the inflammatory response secondary to the foreign body within the esophageal lumen. So this you need to have the patient's history with you, and patient might be on the NGU tube for a quite long time. So this is clear an example of the iatrogenic esophageal benign stricture. The another rare entity is Crohn's disease. Crohn's disease actually it's also a multi-organ disease, but it rarely involves the esophagus. But still, cases are not uncommon. You may be able to see in Crohn's disease there will be a benign esophageal stricture. On this Barium Studies, you may be able to see a distal esophageal small stricture. If you focus on, you will be able to see that this stricture is benign in nature, and there is smooth wall, and there is no significant pre or post stenotic dilatation because of the fact that this stricture is quite small stricture, and this is usually happens in case of Crohn's disease. In the next inflammatory category, there is eosinophilic esophagitis, and it has its own typical presentations on the Barium Studies, although these strictures happens to be quite short in sizes. Here on this image you can appreciate multiple small strictures. This is a very typical pattern for the eosinophilic esophagitis. These are small short strictures but multiple, and also give rise to a pattern which is called as a coil pattern or ring pattern. This is the presentation of the eosinophilic esophagitis, and this would be termed as a small benign strictures. As we have already discussed the inflammatory etiology of the esophageal strictures, the next is neoplastic. As the name shows, neoplastic, it would be because of any neoplasms or tumor. The first comes is carcinoma. Very rarely carcinoma causes smooth wall strictures. However, mediastinal tumors, because of the pushing effects, it may give rise to esophageal strictures which happens to be a smooth wall. The third category is a leiomyoma. Leiomyoma is actually a tumor which is arising from the wall of the esophagus and also give rise to a stricture formation, but this stricture would be of benign nature, and this stricture would be of a smooth wall type. This we will discuss in the next chapter, so because this is a specific entity, and we will have a separate video for this specific neoplastic esophageal strictures. There are some other categories which also causes smooth wall esophageal strictures, and the topmost is achalasia cardia, which I am showing you in the next slide, and the second is the skin disorders epidermolysis bullosa or pemphigus. These two are the skin diseases which also gives rise to smooth wall esophageal strictures. A beautiful example of the achalasia cardia. It's also called as an achalasia cardia because it's just near to the cardiac surface, so that's why it is also termed as achalasia cardia. And the particular sign of this achalasia is rat tail appearance, or it's also called as bird beaks appearance. You can appreciate it's a very tiny strictures at the end, distal end of the esophagus, and it also causes pre-stenotic dilatation. So this is a clear example of the achalasia. In the Barium Studies, what the most important thing is to write the report, to sum up your diagnosis, to sum up your findings. So for that purpose, you should have to have all these 8 points in view. The first and the foremost is you must mention the contrast, that which contrast has been used for this investigation. Mostly barium sulfate is used for the GIT studies. GIT best contrast is the barium sulfate. After that, you have to mention that which method has been used to introduce the contrast, whether it was orally, it was by mouth, or it was by any other means like catheter. So you must mention the method of the introduction, and beside this you should have to mention the anatomical structure which is outlined, whether it was esophagus or stomach or intestine or whatever the thing is. You should have to mention and mention the name of the anatomical structure. After all these discussion, you must mention the propulsion of the contrast, the way it is passing through the organs, and then you must mention whether there is any hold up of contrast at any point, or there was a leakage of contrast at any point, or whether there is any pathology, or there is any diverticulum, or there is any filling defect you are able to see. So you must mention the pathology. After all that, after all these procedures, you should have to have your own diagnosis. First, try to give your own diagnosis, and if you can sum it up with a differential diagnosis, that would be great. And at the last but not the least, you should have to mention the next modality, because like for the management purpose and for the other diagnostic purpose, you need to have the next modality if your physician or your colleague want to confirm this diagnosis on the other radiological imaging. So this is the report writing method, and your report should have all these informations in writing so that your colleague can benefit from your report.